Good evening. I would like to thank the PPS Northern Luzon Organizing Committee for inviting me to be part of the second biennial scientific forum. COVID-19 has impacted greatly our lives and presents an unprecedented public challenge to our health. And the COVID-19 pandemic and pediatric asthma relationship continue to evolve. My objectives for this evening are the following: to discuss the relationship of COVID-19 and asthma in children, to discuss the common concerns on asthma treatment during the pandemic. What are the concerns during the pandemic? Number one, are asthmatic patients more susceptible to SARS-CoV-2 infection? Second, if infected, are asthmatic patients at higher risk for severe COVID-19? And is the relationship between asthma and COVID-19 different according to age and asthma endotypes? During the pandemic in 2020, many countries saw a reduction in asthma exacerbation and influenza-related illness. The reasons are not precisely known, but may be due to hand washing, mask, and social physical distancing that reduce the incidence of other respiratory infections as well, including influenza. Overall, people with well-controlled asthma are not at increased risk of COVID-19 related death. However, the risk of COVID-19 death was increased in people who had recently needed oral corticosteroids for their asthma and in hospitalized patients with severe asthma. What about in children? The COVID-19 in children is less severe and prevalent. The potential mechanisms of milder COVID-19 in children may be due to the following: less efficient internalization of the virus because they have less expression of ACE2, which is the main receptor for SARS-CoV-2 protein. And they also have less expression of your transmembrane protease serine 2, which is necessary for viral fusion with cell membrane. Second, there are more viral co-infection in children, and this can cause a cooperative or competitive interactions which can increase or reduce the viral growth. And this is based on the epidemiological postulate during the 2009 influenza epidemic, which mitigates the RSV epidemic. Aside from this, the third possible mechanism is immunological memory because of the past exposure of children to common coronaviruses, which leads to cross-reaction antibody formation. They also have a distinct immune response, and they have a more effective innate immunity and less strong humoral immunity, which counteracts SARS-CoV-2 more successfully. Children have also fewer comorbidities compared to adults. But in children, there is no systematic testing, so many are probably asymptomatic, and this could also be the effect of quarantine, social distancing, and wearing of face masks. Hence, there's a need for future population-based seroprevalence survey. What is the complex relationship of SARS-CoV-2 and asthma in children? In China, Brazil, and New York, there's no difference in severity between patients with or without allergy, and asthma has not been found to be associated with more severe COVID. A systematic review by Castro Rodriguez also showed that only one report described asthma as a potential risk for COVID-19, and largest studies to date has limited number of cases by age group. So there's still a question whether asthma or other respiratory diseases is associated with COVID-19 risk or severity. In the PEARL study, which is pediatric asthma in real life by Papadopoulos, the population is 1,054 asthmatics and 505 non-asthmatics of ages 4 to 18 years of age. And they compared the frequency of acute respiratory and febrile presentations between the two groups during the first wave and from the preceding year. And the results revealed that in children with asthma, those with in the year during the pandemic, children with asthma have fewer URTI, febrile episodes, ER visits, hospital admissions, and asthma attacks compared from the previous year. And 66% has improved asthma control. There's no difference between asthmatics and non-asthmatics in terms of the lower respiratory tract infection, ER visits, hospitalization, and episodes of pyrexia. The conclusion is that childhood asthma outcomes, including control, were improved during the first wave of the pandemic, probably due to reduced exposure to asthma triggers and medication adherence. They also conclude that this does not support that childhood asthma is a risk factor for COVID-19, and they emphasize the importance of environmental control. So the hypothesis on the protective effect of asthma against COVID is, number one, in children, it's a Th2-driven inflammation. Second, there's predominance of eosinophils, which can reduce the viral load with subsequent attenuation of COVID-19. Inhaled corticosteroids as the main treatment can also cause downregulation of ACE2 and your transmembrane protein serine 2. And additionally, there's also suppression of interleukin 6 and interleukin 8. The European Academy of Allergy and Clinical Immunology forwarded a statement that based on common sense, rather than mounting evidence, children with asthma, particularly severe or uncontrolled, should be considered to be at increased risk of developing severe COVID-19. So with these findings, what are the implications for asthma management? It is important to continue good asthma management as described in the GINA report with strategies to maintain good symptom control, to reduce the risk of severe exacerbation, and to minimize the need for oral corticosteroids. So what are the objectives of managing asthma patients during the COVID-19 pandemic? There's no substantial differences from the usual guidelines. The hallmark of control remains the same, with the objective of treating with minimal medication, utilizing a step-up or step-down approach. However, the current COVID-19 pandemic made access to care more challenging. Hence, patients should be kept on the minimal amount of controller therapy and to avoid withholding the controller therapy. Families should be educated about the chronic nature of asthma and the importance of adherence. Review the inhaler technique. Patients should have a written action plan and follow general recommendations with regards to infection control. As an update, the GINA 2021 treatment figure for adolescents and adults, there are now 2 tracks, which is based on the reliever. The track 1 is the with low dose inhaled corticosteroids formoterol as the reliever, which is the preferred approach. The track 2 is the one with the SABA as the reliever, which is an alternative approach. Treatment may be stepped up or down within a track using the same reliever at each step or switch between tracks according to the patient's needs and preferences. So this is now your GINA 2021 guideline. You have your track 1, your inhaled corticosteroids and formoterol as reliever, and the track 2, which is an alternative, controlled and alternative reliever using your SABA. In each step 1, 2, 3, 4, and 5, as you can see, inhaled corticosteroids is well presented. What about for 6 to 11 years of age? The GINA 2021 treatment figure was updated for consistency with the existing recommendations in the text. And for step 1, children with symptoms less than 2 times per month, taking inhaled corticosteroids whenever SABA is taken is preferred over your daily inhaled corticosteroids. For step 2, daily inhaled corticosteroids is preferred over taking inhaled corticosteroids whenever SABA is taken. Step 3, they now included your marked or maintenance and reliever therapy with very low dose inhaled dose ICS formoterol as an option for children. And step 4, MARC is also included, and patients should be referred for expert opinion. So this is now your 2021 guideline for children 6 to 11 years of age. Before, they did not recommend the low-dose inhaled corticosteroids taken whenever SABA is taken, but now it is now recommended. And again, from step 1, 2, 3, 4, and 5, inhaled corticosteroids is well presented. There's no difference in terms of the management in children less than 5 years and younger. And inhaled corticosteroids is encouraged if the patient has symptoms not consistent with asthma, but wheezing episodes requiring SABA occur frequently, more than 3 times a year. You may give a diagnostic trial for 3 months and consider specialist referral. So, shall we continue using inhaled corticosteroids? The updated asthma guidelines, there's a strong agreement on the asthma medications during the COVID-19 pandemic. However, the use of nebulizer, there are contradicting recommendations. Thus, the international expert opinion on the use of nebulization for pediatric asthma therapy during the COVID-19 presented the following recommendations. Recommendation 1 is that nebulization in pediatric asthma care during the pandemic should be continued, but with caution and adequate protective measures in place. Always observe aseptic technique, physical distancing, and for safety measures specific to home settings, nebulization should be done in a well-ventilated area. Clean, disinfect, sterilize the nebulizer. Follow the manufacturer's instructions. If the manufacturer's instructions are not available, you should clean the nebulizer parts with dish detergent and sterile filtered or tap water. Wipe the compressor with 70% isopropyl alcohol or ethanol. Disinfect using the cold method or the hot method. Cold method, soak in isopropyl alcohol for 5 minutes or in 3% hydrogen peroxide for 30 minutes, and then rinse with sterile water. For hot method, place the nebulizing parts in boiling water and boil for 5 minutes. Or place the nebulizing parts in microwave-safe container, submerge in water and microwave for 5 minutes. Use an electric steam sterilizer such as the baby bottle disinfector. And then afterwards, air dry, then store in the nebulizer parts on absorbent tissue in a dedicated storage box. Safety measures specific to hospital settings: 1 nebulizer per patient as much as possible, negative pressure room, use of HEPA filter, and use mouthpiece rather than the face mask. For the second recommendation, it's just a summary of standard safety precautions such as strict hand hygiene, aseptic technique, physical distancing, and thoroughly cleaning and disinfection of general surfaces of the room with 70% ethanol with minimum contact time of 1 minute. Who are the patients in need of nebulization? Preschool children may need use of your nebulizer. Patients who are currently using nebulization as part of their personal asthma plan. Children who cannot operate your metered dose inhaler plus a spacer. Children with impaired asthma control when using metered dose inhaler. Those with severe exacerbation or too ill to use a handheld device. If with suspected COVID, weigh the risk and the benefit. The studies on the use of nebulized corticosteroids in children, first, the budesonide nebulization was added to systemic prednisolone in the treatment of acute asthma in children, which is a double-blind randomized controlled trial. This is in ages 2 to 12 years old, and the results on the full study population, there's no significant difference. However, on the subgroup analysis, it showed a 58% reduction in the risk of admission of patients presenting with severe asthma in the budesonide group versus the placebo group. A systematic review and global expert analysis on the nebulized inhaled corticosteroids in asthma treatment in children less than 5 years and younger revealed that in the emergency room, the nebulized corticosteroids is as efficacious as oral steroids for mild to moderate asthma exacerbation. For asthma maintenance, nebulized inhaled corticosteroids, particularly budesonide, decrease asthma exacerbation versus placebo, versus cromolyn sodium, and or montelukast. For viral-induced wheezing, intermittent nebulized corticosteroids is as effective as continuous daily treatment. So what about the role of inhaled corticosteroids in the treatment of COVID? The systemic steroids such as dexamethasone and hydrocortisone, there's a clear guideline for patients with severe COVID, but not recommended for mild COVID. In vitro studies of budesonide and cyclesonide on human respiratory epithelial cells revealed that the budesonide has inhibitory actions on coronavirus replication and cytokine production. The cyclesonide blocks SARS-CoV-2 RNA replication and inhibits SARS-CoV-2 cytopathic activity. Hence, a study was done on steroids in COVID-19 or STOIC study, the background of which is that patients with chronic respiratory diseases were significantly underrepresented in adult patients admitted in the hospital with COVID-19. Hence, the hypothesis is that widespread treatment with inhaled corticosteroids among these patients was responsible for this finding. So, is inhaled glucocorticosteroids an effective treatment for early COVID-19? This is an open-label parallel group phase 2 randomized controlled trial of inhaled budesonide 800 microgram per day versus the usual care in adults within 7 days of the onset of mild COVID symptoms in a community in Oxfordshire, UK. And the primary endpoint revealed that patients with budesonide has a 1% versus 14% in the usual care in terms of the decrease in the COVID-19 related urgent care visit at ER and department hospitalization. So for those in budesonide, only 1% was presented compared to the 14% ER visits in the usual care. The secondary endpoint, the symptom resolution, the viral symptoms, and the body temperature was also improved in the budesonide group compared to the usual care. There's no difference in terms of oxygen saturation and SARS-CoV-2 viral load. So their interpretation is that early administration of inhaled budesonide reduced the likelihood of needing urgent medical care and reduced time to recovery after early COVID. Another study, which is an ongoing study, is the principal study, Platform Randomized Trial of Interventions Against COVID-19 in Older People. Multicenter, open-label, multi-arm, adaptive platform randomized controlled trial of older people. The interim analysis is that inhaled budesonide reduced time to recovery by a median of 3 days. Final analysis is pending. Unfortunately, there are no studies in children with regards to the budesonide in mild to moderate COVID. So what about oral steroids in asthma? The short courses of steroids are frequently used as a rescue therapy in asthma exacerbation, and the apparent risk with steroids is far less than the benefits of aborting an exacerbation. Hence, prescribe short course oral corticosteroids 3 to 5 days if clinically indicated. So, patients who fail to respond to reliever and controller medications for 2 to 3 days, those with rapid clinical deterioration or with peak FEV1 or PEF of less than 60% predicted or personal best, those with history of sudden severe exacerbation, give oral corticosteroids. In children less than 5 years old, urgent medical attention is needed if child is acutely distressed, child symptoms is not relieved promptly by bronchodilator, or period of relief after doses of SABA becomes progressively shorter. A child less than 1 year requires repeated inhaled SABA over several hours is also in need of urgent medical attention. What about follow-up? It should be done within 1 to 2 weeks, or if given oral steroids, early follow-up is recommended. Because of the COVID-19, alternative ways of remote follow-up is recommended, such as virtual clinic, phone calls, and telemedicine. What about pulmonary function tests? This may potentially increase the risk of COVID-19 transmission and should be avoided as much as possible. In summary, the current pandemic of COVID-19 in children is often a mild and self-limited disease as of present times. However, for the last 1 to 2 months, we have been having a lot of cases of COVID-19 with moderate to severe cases in children. So the battle is not yet over. The pandemic have changed many medical practices for both patients and healthcare providers, and interim guidelines will continually adapt to the changing times. The prophylaxis for asthma should continue as planned. Asthma action plan should be provided, and meter dose inhaler and spacer is the preferred way for bronchodilator, and spirometry should be avoided. Thank you very much for your kind attention.